Okay, so good afternoon. So it's last day of this icon this year, and I thank the organizers for giving me this opportunity. So today I will be talking on real world evidence Osimertinib as the standard of care in the management of EGFR mutated non-small cell lung cancer. So in patients with EGFR mutation, PFS improves after the treatment with EGFR TKI as compared to the cytotoxic chemotherapy which we had earlier. And Osimertinib and irreversible third generation EGFR TKI demonstrated a clinically meaningful improvement in the median progression-free survival in a phase 3 randomized trial known as the FLORA trial. We have been hearing this from in these last 3 days multiple times. The overall survival, median overall survival was 38.6 months compared to 31.8 months in the comparator arm, made Osimertinib the best treatment option for patients with untreated EGFR mutated non-small cell lung cancer. So this is the Osimertinib versus the comparator EGFR TKI as the first line treatment, the FLORA trial, the final overall survival. This is the trial design in which patients with locally advanced or a metastatic non-small cell with an EGFR mutated exon 19 or an exon 21 L858 were taken into the study, and it was stratified into Osimertinib 1 versus the comparator with EGFR TKI like the Gefitinib or the Arolutinib in the opposite arm, and crossover was allowed for patients in comparator EGFR TKI who could receive open label Osimertinib upon central confirmation on progression and T790M positivity. So overall survival was a key secondary endpoint. Final overall survival plan was approximately after 318 death events had occurred. For statistical significant, a p-value of 0.04 was taken. So these were the baseline characteristics, which was well matched in both the arms. And what we see that the CNS metastasis at study entry was 19 patients in the Osimertinib arm, whereas in the comparator arm it was 23. So the primary analysis of progression-free survival which we had in the Osimertinib arm, which was 18.9 months versus 10.2 months in the comparator EGFR TKI arm, which was clinically and statistically significant. And the forest plot, when we saw the forest plot, it favors the Osimertinib arm in almost all the subsets which we analyzed, which had been analyzed even with the CNS Mets patient also. So the final overall survival which we had, it was the 38.6 months in the Osimertinib arm compared to the 31.8 months in the comparator arm with a p-value of 0.04. So the conclusion of the FLORA trial was it showed statistically significant and clinically meaningful improvement in the overall survival with Osimertinib. Median overall survival for patients in the Osimertinib arm was extended by 6.8 months. And it's the first EGFR TKI monotherapy to show a statistical significant overall survival benefit versus another TKI. After 3 years, 28% of the patients in the Osimertinib arm and 9% of the patients in the comparator arm remained on the first line treatment only, and the patient presented a favorable and consistent toxicity profile despite the prolonged exposure to Osimertinib. The final overall analysis of the FLORA reinforces the Osimertinib as the standard of care for first line treatment of patients with EGFR mutated advanced non-small cell lung carcinoma. So when we see the NCCN guideline also, EGFR mutation which was discovered during first line treatment, if the patient was on, we can switch to Osimertinib if it was discovered after the first cycle or the second cycle, and also if it is discovered prior to that, we can use the Osimertinib upfront from first day onwards. So the real world evidence of Osimertinib is the thing which we are looking to today. So there were 3 studies which were performed. One was the FLOWER study, one was the OCFACT study, and one is the Mykonos study. So this is the FLOWER study in which the Osimertinib demonstrated a clinically meaningful improvement in the median PFS of 18.9 months in the FLORA trial, and overall survival which we said, it has been estimated that 2 to 4% of the patients with cancer receive treatments within the RCT, thus raising the issue of representativeness in the general population. So real world data have become useful tools to assess the unique insights in routine oncology practice in the post-marketing surveillance setups. So these in the FLOWER trial, the key features in the baseline characteristics which we had, the median age was 68 years, which is well represented, and of course the brain metastasis at diagnosis was 30.2% of the patients were included who were brain metastasis at baseline. Most of the patients were stage 4A or a stage 4B. These were the three things. This is the study inclusion and the exclusion criteria, which was like that. And the diagnostic, this is the study endpoints, mainly the time to duration, disease progression, and the rate of treatment related adverse effects, the rate of dose reductions or the and temporary or definitive treatment interruptions. Secondary endpoints were median overall survival, median PFS, overall response rate, and the disease response rates. So the primary assessment of effectiveness, which we saw that patients with a poor performance status, comorbidities, and rare EGFR mutations and active brain mets were included, which were excluded in the FLORA trial, and outcomes were similar to published data, thus adding consistency to the efficacy of the Osimertinib. No difference in the progression-free survival or time to disease progression or overall survival were noted in elderly patients, patients with comorbidities, and less common EGFR mutations. So this is the time to discontinuation and no symptom median not reached. That was median time to duration in the patients with or without symptoms at diagnosis, and median time to duration in patients with less than 3 or at least 3 metastatic sites. Both were better. So what we see, that time to treatment duration was longer, 25.3 months, than the post progression outcomes analysis in the FLORA trials, which was 20.8 months. Probably due to study population unfit for further therapy and different therapy for oligoprogressive disease. So better time to treatment discontinuation was associated with a fewer than 3 progressing sites and isolated progression compared to oligo or systemic progression. So poor treatment outcome for patients with brain metastasis, presence of symptoms and at least 3 metastatic sites at diagnosis, suggesting a tumor load as a negative prognostic factor. So what we saw, that the symptoms at diagnosis which was present and absent out of this, which was clinically significant in the real world evidence which we saw. And then again another one is the less than 3 or the more than 3 sites at diagnosis was also significant. So after a median follow-up of 12.3 months, the median PFS was 18.9 months. And median OS was not reached at the time of data cutoff, where 81% of the censored subjects were used. The PR and the stable disease rates were in the rate range of around 90%, and 4% of the patients progressed on the disease on treatment. So longer PFS was noticed in absence of brain metastasis, that is what we know, and prolonged PFS and longer overall survival was also noticed in patients without symptoms at diagnosis. So time to treatment discontinuation of 9 months or higher was significantly associated with a better overall survival. And the real world diagnostic therapeutic pathway also essential element of evidence based medicine and could help clinician in decision making. So among patients expressing progressive disease, 21 cases underwent a rebiopsy at progression, which we should do ideally, and tissue rebiopsy in 14 cases, and liquid biopsy can also be done with cell-free DNA to see the T790M mutation status. And molecular analysis was performed in 13 samples. The druggable resistance mechanisms included the MET amplification in 4 patients, the MET and EGFR amplification in 1 patient, and EGFR amplification in 1 more, and HER2 amplification in 1 patient. So safety wise, what we saw, that most common side effect was diarrhea and skin rash, which was seen in around 30-35% of the patients, and some patients also experienced venous thromboembolism. So next comes the safety data. 110 patients and 87% of the experienced adverse of this 110 patients, 87 adverse effects of any grade, and grade 3 or 4 side effects was experienced in only 33% of the patients. So venous thromboembolism was more common in the real world AstraZeneca study. Grade 3 pulmonary embolism accounted for 2% of the pre-treated population receiving Osimertinib. So no difference in rates of venous thromboembolism was reported according to age, performance status, comorbidity, and the tumor load. So no difference in survival outcomes was observed according to age, comorbidity, and the type of EGFR mutation. Osimertinib confirmed the effectiveness and the safety in the real world scenario. So next comes the OSIFACT study, which was also a real world done in the real world setting. So it investigated the efficacy with patient background and the safety of first line Osimertinib treatment in the real world scenario. So this was the study inclusion criteria, the baseline characteristics, which was also well matched. The median age was around 71 years with the good and the with a good population. PDL1 was TPS score was also measured in these patients. So the study endpoints, primary endpoint was progression-free survival, and the secondary endpoints was overall survival, time to treatment failure, response rates, objective response rates, and the disease control rates. So progression-free events occurred in 182 of the 538 patients which were taken, of which the median PFS was 20.5 months, and this arm. So the other parameters significantly associated with PFS was the males had better response, malignant diffusions, liver metastasis, and advanced unresectable cases. With respect to PDL1, the median PFS was not reached in the patients with TPS less than 1, 14.7 months with TPS less than 49, 11.1 months with those more than 50%, and not reached in patients in which TPS was unknown. So what we saw that if the TPS score is less than 1, it had a better effect with osimertinib. So this is the treatment discontinuation profile, of which what we see that disease progression is the most common. 44.3% was due to disease progression, and yes, 25% was due to pneumonitis, which was due to the drug. So adverse side effects which we saw, pneumonitis is one of them, QTC prolongation is one of them, and reduced ejection fraction or cardiac dysfunction is also one of them. So conclusion, overall response rate was 76.2% and the disease control rate was 94.1%. PFS was better with osimertinib than with the conventional EGFR TKIs irrespective of the PDL1 overexpression. Median time to progression was time to treatment failure was 19.1 months. The median time from the start of treatment to the onset of adverse effects was 56 days. Pneumonitis of all grades occurred in 69 patients, grade 3 or higher occurred in 24 patients, and fatal pneumonitis occurred in 4 patients. So the conclusion was PFS after first line osimertinib treatment in real world practice was favorable. The discontinuation rate due to adverse effects, especially pneumonitis, requires further investigation. And this is the third one, real world evidence which we had. This study reports the demographic and the clinical characteristics of this EGFR mutated lung cancer who received first line osimertinib in the US. So it was a global observation prospective cohort ongoing in the US, Europe, and the Asia that involves analysis of registry and electronic health records. So patient inclusion was more than 18 years, advanced stage, EGFR mutation documented prior to initiation of first line monotherapy with osimertinib, and it was started from April 2018 to March 2020. So this is the assessment and statistical analysis. So what we saw that, so the EGFR positive patients was 548, out of the common mutations occurred in exon 19 occurred in 280 patients, L858 occurred in 185 patients, totally accounting to around 88% of the patients, and exon 19 deletion plus L858 occurred in 4% of the patients. So common and both common and uncommon mutations was seen in also 4% of the patients. So at the interim analysis of 318 patients, that is 58% of the patients remained on first line osimertinib therapy or were lost to follow up. 18.8% of the patients received second line treatment and 18% died while on first line treatment. 4.7% discontinued treatment when they were on first line. So median follow-up time was 9.6 months, and in the multivariate analysis following, these variables were significantly associated with the stage at initial diagnosis, the smoking status, the Charlson's comorbidity index of more than 3, and EGFR mutation subtype. So real world time to treatment discontinuation rates was 17.2 months, in which 230 events had occurred, of which 101 patients had died, 103 patients had switched to second line treatment, and 26 patients discontinued treatment. So in the multivariate analysis also, following variables were significantly associated with what I said. So this study provides the real world insights into the use of first line osimertinib in the patients with advanced EGFR mutated non-small cell lung carcinoma based on the first data cut of the US subpopulation, the interim real world evidence treatment to discontinuation and treatment to time to treatment discontinuation results support the effectiveness of osimertinib in the real world population, and longer term outcomes will be evaluated in the final one. So with this I end my talk and I am free to take questions.